move right along. Our next speaker is Dace Svikis, and she is a professor at the Department of Psychology, Psychiatry, and OBGYN at UCU in Richmond. She's also the Director of Addictions and Women's Health, Advanced Research and Evaluation at UCU. And she'll be talking to you today about addictions, mental health, everything else we want to know.
It is a pleasure to be here today to talk with you. I confess when I first heard about this opportunity to talk about sort of what's new in addictions and mental health, I was really excited about that and had to pause and think about really what are the new things that have happened in the past year. And that excitement led to, unfortunately, my inability to necessarily pare it all down. So for those of you who might have looked at the slides for this particular talk, I'm not going to actually go through all of those today, and my intent wasn't to kill trees. I've shortened some of what I'm going to say, but I really still wanted to give you the information, so the slides are lengthier than what you'll actually be hearing. The other thing I want to do is just say that I returned recently from Minnesota, where it's still snowing today, by the way, and whatever I caught is lingering, and when I talk, it actually causes me to cough more, so I apologize in advance for that, and I will try to keep it under control. All right, so let's see, how's this work? That's not it. Oh, there we go, okay. All right. So these are the topics that I selected to talk about today. I want to talk a little bit about screening in the form of SBIRT. I want to tell you about what's new in diagnosis, since there's a big change coming up next month. I'm going to spend some time talking about synthetic cathinones, otherwise known as bath salts. And then I want to talk a little bit about the prescription drug use and abuse epidemiology and sort of what's been happening recently overall, and then talk specifically about prescription opiates and tell you a little bit about a recent treatment study with prescription opioid dependence. All right, so the first thing is SBIRT. How many people here are familiar with the acronym SBIRT? Oh, just all right, that actually surprises me. So SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. It is still the gold standard. It actually has been recommended for a number of years now, but the data coming out continue to suggest that it's one of the most effective things that we can do as sort of a first step in looking at people's substance use and abuse. And it's described as a comprehensive and integrated approach to the delivery of early intervention and treatment services through universal screening for persons with substance use disorders and those at risk. That's a mouthful. So let me tell you what that really means. So SBIRT is a way of finding out if a person is using and how much they're using and whether they're having problems. And if they essentially screen positive, then you go on to the BI piece to it, which stands for brief intervention. And then if they're interested at the end of that, you go on to treatment referral. So part of the reason why it has remained popular is that it can be taught to a very diverse group of people. It doesn't really require specific addiction treatment experience. Second, it views alcohol and drug abuse not as a you've got it or you don't. It really looks at it much more as a continuum with different degrees of severity. And that fits really nicely, parallels what's happening with the DSM diagnostic system that we'll talk about in just a little bit. And it uses a very non-confrontational style in its delivery. How many folks here are familiar with motivational interviewing? That's a bigger group. So the brief intervention piece to SBIRT uses a motivational interviewing sort of style, very non-confrontational and non-judgmental. Part of why SBIRT has been so popular is also the increased recognition that it can be used for both prevention and treatment. It can look at trying to have a conversation with a person to prevent their alcohol or drug use from escalating and leading to negative consequences, or it could try to intervene if they're already starting to have some problems, but earlier in the progression of those problems. And then for some people, it actually is treatment. And I can't emphasize this enough. The studies have really consistently shown that the brief intervention piece of SBIRT actually works with some people who don't need to necessarily go on to formal treatment thereafter, that actually will make decisions to change their drinking or potentially use community resources to actually make a change. So it really targets a diverse group of individuals. SBIRT is being used in more and more settings. Primary care is probably the predominant one historically, but it's also being used in trauma centers. It's used in emergency rooms, in community health centers, and more sites are considering this with every passing month. So the screening piece to SBIRT has two pieces to it that I think are important to think about. Number one is more important than almost any of the rest of it is how you ask the questions about alcohol and drugs. So if you start it with something like, "You don't use drugs, do you?" that probably isn't going to get you a whole lot further. It's really supposed to be that sort of non-judgmental, matter-of-fact, motivational interviewing-based discussion with the individual. And then the second thing is you want to obviously be using items or tools that are reliable and valid, that you can then rely upon to tell you who you want to go on to talk to about brief intervention. So I view the screening piece as kind of like your GPS. You know, when you boot up where you want to go, you can have the short route, you can have the fast route, or you can have sort of the scenic route. Same thing is true for the screening piece of SBIRT. How many questions you ask and how long it takes is really sort of your decision, what works in the setting that you're in, and a number of other things. So these are some of the sort of traditional tried and true instruments. How many folks here are familiar with the AUDIT? Okay, that's right again. So the AUDIT is 10 items. It is probably one of the more consistently used, well-validated, was developed by the World Health Organization and Tom Baber. It's 10 items that screen for alcohol use and problems, and is very reliable in picking up who might be a problem drinker. The CAGE is 4 questions. You can ask it separately for alcohol or for drugs. You can ask it for both of them combined, and I'll show you that in just a minute. The assist is a little bit longer, but is advocated for if you want to really look at alcohol, drugs. It will look at different drugs separately to get sort of a more detailed evaluation. The CRAFT is one that's used for adolescents, and the TACE and the TWEAK are kind of variants on the CAGE, and they're specific to pregnant women. So they're screeners that really have been developed to identify whether a pregnant woman might be drinking during pregnancy. If you want copies of any of these, we can certainly make sure that those are available through the website along with the slides. But let me just show you one in the interest of time. So this is the CAGE. This is the one that we spend a lot of time training physicians to use in medical practice, because it's 4 questions, and there's the mnemonic for remembering it, CAGE, and physicians love mnemonics. So it's, have you ever felt you should cut down on your drinking? And again, you can also do drug use, alone or separately. Alone or together. Have people annoyed you by criticizing your drinking? Have you ever felt bad or guilty about your drinking? And have you ever had an eye opener first thing in the morning to steady your nerves and get, rid of a hangover? When you look at the epidemiological data, a score of 1, so 1 yes response or more for women, is indicative that you should go on to have the subsequent BI conversation. For men, it's traditionally 2 yeses, so any 2 yeses would suggest that. Now, scoring 1 or for men 2 doesn't mean the person necessarily has a problem or has a substance use disorder. It's a screener. So when you're screening, you're finding who are the likely people, and then you're going to go on to ask more questions as part of a potential intervention thereafter. In terms of what's new, the AUDIT-C is a shortened version of the 10-item instrument I mentioned to you recently that's been used really extensively. And so I think this has been a really nice addition to sort of your armamentarium of screening instruments, because 3 questions take a lot shorter time than 10 to answer. And it tends to really look at sort of the quantity frequency component of drinking, less so than specifically problems. So the 3 questions are, how often do you have a drink containing alcohol? And it goes from never to 4 or more times a week. How many standard drinks containing alcohol do you have on a typical day? And a standard drink would be a 12-ounce beer, a 5-ounce glass of wine, or 1 shot of liquor. And it is always important to remind people that beer and wine are alcohol, because there's still a large segment of society that doesn't necessarily know that. So up through 10 or more. And then how often do you have 6 or more drinks on one occasion? And it goes from never to daily. So essentially, you ask those 3 questions, and then you score it. And the first response in each of those categories gets 0. The highest, most intensive response gets 4. And you add them up. And for males, if they score 4 or more, they're considered positive again, essentially at risk to go on to have more of a conversation with them. In women, it's a score of 3 or more. And really, this tends to be quite valid and reliable. So using this for alcohol and then potentially one of the other tools for drugs is not a bad way to accomplish the screening piece to this. So brief intervention, the next piece to this, is essentially any time-limited effort that you would use to provide things like information and advice, particularly advice if the person asks for it, to increase the person's motivation to avoid substance use using the principles of motivational interviewing, and to teach behavior change skills to either reduce substance use or decrease the probability of negative consequences. And there are a number of different brief intervention models that have been developed and are used, some more in primary care, some in other counseling settings. And I'm not going to spend a lot of detail on that because there's a lot more I want to talk about today. In some settings, that brief intervention isn't sufficient, and you might actually go on to brief treatment. This requires additional training and expertise, but for those of you who are in the addictions field, this takes, it's typically 2 or 6 sessions after the brief intervention. It uses principles of both cognitive behavioral therapy and a variant on motivational interviewing. It could involve pharmacotherapies if the person might benefit from them as part of that too. So this is something that could target somebody at higher risk, but who might not be interested in or ready for formal treatment. This would be another interesting step in between. And then the last part to this is referral to treatment, but again, that's not necessarily, it certainly doesn't happen with everybody, and it isn't even necessarily the most typical thing that happens. As a matter of fact, a lot of people have started to call it just SBI, screening and brief intervention. And then, again, if warranted and the person is interested, the referral to treatment. And in terms of what's new in this particular component to it, it's really that there's been a lot more work on networking and doing exactly what we have here, bringing people together from the different pieces to the system to communicate with one another to really make sure that there can be referrals, that they can happen in a timely manner, and that if the person is interested in treatment, they can get in as quickly as possible. In terms of mental health screening, I actually probably get asked this more frequently than I do about screening for addiction. There are a number of screeners, most of them specific to one condition. So there's the CESD. How many of you are familiar with the CESD? It's a brief screen for just depression, but after you ask those questions, you're only going to know if the person's at risk for being depressed. And there's similar things for anxiety, et cetera. The modified mini screen is a nice compromise. This is a kind of more generic screener for mental health, and it will look at the mood disorders and anxiety and psychotic disorders as well. And it's 22 questions with yes/no responses. It takes about 15 minutes. And the questions are things like this. Have you been consistently depressed or down most of the day, nearly every day for the past 2 weeks? And in the past 2 weeks, have you been less interested in most things or less able to enjoy the things you used to enjoy most of the time? Have you worried excessively or been anxious about several things over the past 6 months? So that pulls for some of the anxiety disorders. And again, there are more questions. Have your relatives or friends ever considered any of your beliefs strange or unusual? And have you ever heard things other people couldn't hear, such as voices? So that starts to get into the psychotic realm, or people who have strange family members. Yes. Pardon? Oh, okay, all right, that's great. Okay, that's great. And this one is essentially, again, it's pretty easy to score. It's 1 point per yes, and a score of 6 or more across all the questions indicates that there might be a psychiatric disorder present and it warrants further attention. And then there are questions specifically there that also are flagged that the person might be at suicide risk. And also there are some questions that suggest that you'd want to follow up on potential PTSD. So any questions? I know that that's not a comprehensive review of SBIRT, but I really do want to get a chance to kind of give you a smattering of things that are new in the addictions field. But any questions about the SBIRT philosophy, sort of, or kind of the components? Particularly the screening, because we're going to talk about that a little bit more subsequently as well. Okay. Let's move on to diagnosis. So it's perfect timing to be giving this talk today because the new DSM system is officially coming out in May, next month. And so it hasn't been revised since 1994, so it was probably due for it. So when DSM goes into a change, every disorder gets its work group, and people start to look at what the literature suggests and how well are the current criteria working, and do we need to change, and if so, what do we need to change? And so for the substance use disorders, when the committee met and was reviewing the literature, there were a couple of things that were noted. One, that there was a lot of trouble with the term dependence. And in particular, confusing physiological dependence with addiction. So, and particularly as prescription drugs are being prescribed more and more. So a person who is a chronic pain patient, for example, who is taking an opioid every single day, that person will be physically dependent upon that medication. But if they're using it as prescribed, they're not taking more than prescribed, they're not addicted. There isn't the second piece to this, that compulsive drug-seeking behavior. And so it was getting confusing to sort of talk about dependence and then have to always do the caveat of, except for people that are chronic pain patients. So that was one problem. The second problem was that the studies really weren't supporting having a diagnosis of abuse with essentially a single criterion. So there were 4 items that you could look at, but meeting criteria for any one of those got you a diagnosis, and that just wasn't as reliable and valid as people would hope for a diagnostic system. And then there were the people that were falling through the cracks. So the criteria, you look for abuse first, and if they meet one of the 4, you go on. If they don't meet any of those, and you move on to the dependence criteria, at that point, you have to meet 3 of the criteria. And so you got the people that were meeting only 2 of them that were in between. So they didn't meet any of the questions under abuse, but they didn't meet enough for dependence, yet they were clearly expressing some of the symptoms. And so they were sort of lost in the void in between. There also wasn't good data to support that abuse and dependence were really different from each other either. And so the new system is now going to view abuse and dependence as a single diagnosis, but with graded clinical severity. So a little bit like what I was just talking about in the screening piece, seeing people as kind of on a continuum. And the new name for the category is going to be substance use and addictive disorders. And the primary change is that craving has been added as one of the potential criteria for diagnosis, which wasn't there before, which is sort of, in many ways, a long time coming. People have had discussions about craving, from does it exist to how do we measure it, for decades. And so I think there finally has been enough literature to suggest it can actually be listed diagnostically. And then the next one is a little bit more controversial. They dropped the item that looked at law enforcement as part of the criteria, so getting into legal problems because of your drinking or drug use. And they did that because at a global level, that could vary so much across countries, but there are other people that are still having some concerns about that no longer being in the system to contribute to a diagnosis. So I'm going to run through the next few slides really quickly, but just to kind of review. So much of this is the old DSM-4 system, but now modified to kind of meet DSM-5. So it remains that you need to have a maladaptive pattern of substance use that leads to clinically significant impairment or distress, having 2 or more of the following within any 12-month period. So now out of this list of symptoms that I'm going to run through, a person who meets at least two of them, will get a diagnosis of a substance use disorder. It's the 0 and 1 category that would not. And again, these criteria are largely the same as from the previous. So it is recurrent use in a situation that is physically hazardous, like driving while intoxicated. Continued use despite having persistent or recurrent social or interpersonal problems, getting into arguments with the spouse, etc. Tolerance, which was in the old criteria as well. So needing markedly increased amounts of the substance to get intoxicated or the desired effect, or getting a lot less of the effect using the same amount. Withdrawal, as manifested by a characteristic withdrawal syndrome for the particular substance that they're taking, or that they're taking the substance to avoid experiencing those symptoms. Taking the substance in larger amounts or over a longer period than was intended. Having a persistent desire to cut down or unsuccessful attempts to cut down or control their use. Spending a lot of time trying to obtain the substance or using the substance or recovering from its effects. Having important social, occupational, or recreational activities that are given up or reduced because of their drug use. Continuing to use despite the fact they know it's a problem and have not been able to act on that. And then the new one is craving. So essentially what you're going to have in the new system are the abuse and dependence criteria largely put together. Craving has been added and the legal question has been taken off. So there are 11 symptoms in total. And then the other new piece is that there's going to be a severity specifier. So 0 or 1 criterion is going to be no diagnosis, but then if you meet 2 or 3 of the criteria, it will be considered a mild substance use disorder. 4 or 5 will be moderate, and 6 or more will be severe. And then you'll be able to characterize whether it's with or without physical dependence. So this is really a significant change. It really is going away from the categorical, they have it or they don't, and moving on to degrees of severity, essentially, for it. And then there will be a variety of specifiers, and I actually don't want to say too much about this because there's still really, until they release it in May, it's not in final form, and so a number of these things have still generated some controversy, and so people aren't exactly clear what's going to be in the final release, but essentially it's going to be looking at different specifiers for what constitutes remission and the different degrees of remission, whether they're on an agonist therapy like methadone, and if they are in a controlled environment like jail. And then there's a new addition. So it's substance use disorders are now going to include gambling. So gambling used to be under impulse control disorder, not elsewhere classified, and now it's going to be classified as an addictive disorder with the drug use categories. They didn't put in caffeine use disorder yet. There's been discussion of internet use disorder, and they decided that there isn't enough data to actually put it in as a diagnosis, but it's in a category that's needing further study. So they're going to be trying to collect data on that going forward. And then they're looking at neurobehavioral disorder associated with prenatal alcohol exposure. Isn't that interesting? Any questions about that? Yes. Yes, yeah, I believe that yep, yeah, it's between between the axis, yeah, in a number of the disorders that used to not be classified as classified on other axes are not going to be listed under a single system, essentially. Yeah. Any questions?
Yeah, I'm just wondering why they're not paying attention to cyber addiction, because it has hurt a lot of relationships, it has hurt a lot of people's functioning at work, and it's becoming an increasing referral in mental health.
I absolutely agree with you. And I hate the fact that I'm being taped when I say what I'm about to say now. But the reason for that is that there is a real push to only make changes in the system that are based on empirical data. And it just hasn't been around and studied enough to be able to actually do that. And the perfect example of that is pathological gambling. We all know that that's been around for a very long time, and people, there are treatment programs, et cetera. And there were even issues about putting that under the addictive disorders sort of piece to it. So I think that from DSM-5 to the next version, hopefully there'll be enough research data coming together to talk about that. I'm not positive of exactly how they're going to do that, but I think there's actually going to be a section on just disorders needing further study, sort of, conditions needing further study. And that, they can be considering where to put that within that system. Any other questions about that? Okay. Otherwise, let's move on to talk about bath salts. And I want to acknowledge two of my colleagues, Lori Kaiser-Marcus and Lori Safford, who contributed a number of the slides you're going to see that follows, and the organizations that they worked with to put together. There's actually a really wonderful 1-hour presentation on bath salts that they do that hopefully will be available on the web for anyone who's interested in the coming months. So bath salts have been in the media for quite a bit. I'm sure everyone has seen some of the news articles and some of the cases of pretty dramatic things associated with them, like people gnawing off other people's faces and a variety of things that have gained attention. So I want to talk a little bit about what are bath salts. So they are an emerging family of drugs that contain one or more of the synthetic chemicals that are related to cathinone. And that is an amphetamine-like stimulant that is found naturally in the khat plant, which can be found in countries such as Yemen and East African countries like Ethiopia and others. The effects of bath salts are largely energizing or agitating effects because it is in the stimulant class. Also a sense of euphoria, greater sociability, higher sex drive, but they can also produce paranoia, hallucinations, delirium, and have been responsible for several instances of death. How do they affect the brain? So the common synthetic cathinones in bath salts include an unpronounceable, I've been practicing this, methylene dioxypyrovalerone, which is MDPV, which is why they gave it that acronym, methadone, and pyrovalerone. And they work by stimulating release and inhibiting reuptake of dopamine, norepinephrine, and serotonin, and in many ways mimic the effects that you might see with cocaine, methamphetamine, and LSD and ecstasy. So it's always hard for me to keep those things straight in my head, and as I was putting this together, this is actually from a PBS presentation that happened on bath salts, but in my mind, it helps me kind of keep things straight. So if you think about this sink as being the metaphor, in a normal brain, small amounts of dopamine are being constantly released. If you think about cocaine interacting with that, cocaine blocks dopamine reuptake. So it's kind of like putting down the plunger, stopping up the sink. If you think about methamphetamine, it really releases a surge of dopamine. So it's like turning the faucet on full blast and watching it go down the sink. And then if you think about bath salts, it does both of those. So it releases a surge of dopamine, and then it blocks the reuptake. So essentially, the sink overflows. A reason to support PBS. Okay. Bath salts are sold in small plastic foil packages that look sort of like that, or can look like that. It's a white or brown crystal powder in most cases. And it's labeled not for human consumption. And it's marketed under a variety of things, in some cases as plant food, what's known. Now, it's not to be confused with, like, bath salts, Epsom salts, okay, where the real main enhancement to that is related to taking a bath. So these are not the bath salts that I'm talking about, okay? Where can you get them? Online, on the internet, along with everything else. Drug paraphernalia stores, and often in gas stations or convenience stores was the other place typically available. And I could fill slides with the brand names, and I'll talk about why that is in just a minute, but common names include Ivory Wave, Bloom, Cloud9, Lunar Wave, Vanilla Sky, Scarface, and White Lightning. They're usually sold in like 300 milligram packets. An average dose is between 5 and 20 milligrams, but you can start to see effects even at doses as low as 3 to 5 milligrams. It's typically snorted or swallowed, but it can also be smoked or injected. And it's a relatively cheap high. So it's about $25 to $50 to buy a packet. And you can get it again as tablets or capsules or powders. And remember, a packet is 300 milligrams. So let me try to kind of condense the history of bath salts for you just a little bit, a couple of sort of the most important things. So from about 2007, 2008, it was a very popular European club drug. And it was in 2010 that it was made illegal across most of Europe. And it was right about that time that it made an appearance in this country, and it became very popular as a legal high. And the first year that that was happening, the U.S. Poison Control Centers received 302 calls related to bath salts. And so as a function of the data coming in about the problems associated with it, in October of 2011, 3 of the synthetic cathinones were put under an emergency ban by the DEA. And then in July of this past year, President Obama made 2 of them illegal, MDPV and mephedra. So the reason that there's still lots of problems with this is because it is labeled not for human consumption. It is not FDA regulated. So that's how they get past a lot of the things that would make some of this easier to monitor and control. So MDPV and mephedrone are illegal. And the legislation does say that it bans things that are similar to it. But as soon as that happens, the chemists start going at it and make things that are different enough that it becomes technically legal again. So they're working one step ahead. And a good example of that was when mephedrone was banned in the UK in 2010, a new chemical called naphorone replaced it, and it was sold as jewelry cleaner under the name Cosmic Blast. Intoxication effects usually occur within 15 minutes, often peak at about 1.5 hours, but a high can last 2 to 6 hours, and then redosing is typical, usually somewhere between 45 and 120 minutes after the initial use. That was to make sure you were all still awake, by the way. The other high-risk behaviors associated with it are injection drug use, high-risk sexual behaviors, again, particularly in part because of the sexual arousal effects, and then a risk of blood and bodily fluid exposure due to the violent behavior associated with it. Remember, I said that some of the ER admissions were what led to the increased attention to it. So overdoses and ER admissions have been one of the main problems. And the common symptoms in this case have been cardiac symptoms. So again, remember, it's like a stimulant, heart racing, high blood pressure, chest pains, but then also the psychiatric symptoms. So presenting with real paranoia, hallucinations, and panic attacks. Detox from bath salts will include symptoms like fatigue, depression, less appetite, and inability to sleep. As the psychosis resolves, depression and suicidal ideation may occur, persistent mood changes that can last days or continue for weeks, and there's the potential for flashbacks with this. So, much of that will sound like what you might expect for other stimulants as well. There hasn't been a lot of research with bath salts, in part because it's hard to measure who's been taking them. The assays aren't available, and the chemical composition continues to change. But in a study at the Michigan, one of the emergency departments in Michigan, with 35 cases, found that 54% were male, age range 20 to 55. 2/3 had a history of drug abuse. 31% were polysubstance. 34% had a history of intravenous use, and 46% had mental illness. So what does that sort of look like to you? It's not all that different from other individuals that are having addiction problems. A study from Europe with more than 2,000 clubbers found that over 40% had used some form of bath salts, and more than 30% had used within the past month. There's been a lot of popular press attention to, like, why call them bath salts? This is confusing. Can't we call them something else? And the quote I like the best is, while it certainly doesn't have the ring of ecstasy or spice, it still is much easier to say than 3,4-methylene dioxyramine. So I'd still vote for bath salts under that. So because of the places that they're generally available, I mean, you're not going to find this where you would typically be buying jewelry cleaner. So I think that is in part, but I mean, certainly I think that those are concerns. I mean, it really got a lot of people doing the reverse. It got people being careful about bath salts. I think this gave bath salts in general a bad rep in terms of Calgon and those things, sort of in the opposite direction.
Is there really any evidence that people are likely to eat off other people's faces on a regular basis?
So I'm not sure that that's been proven yet. And again, the answer is in part that we really don't know. But I guess I tend to be cautious about these things too, because it really is gotten a lot of media attention. I think it's clearly a drug with significant abuse potential because it's a stimulant. And I guess when I look at the ER admission data, that looks to me just like if the person was coming in primarily for cocaine or for sort of other drugs. So I don't know that ultimately they will find that bath salts are significantly worse than other drugs that are available. I think that they have the additional piece to it of not being labeled not for human consumption, where they're not regulated, and that the chemists can change the formulas really quickly, and then we don't have a good assay to know what they've actually used and how much. And so it's going to be much more difficult to study some of the things relative to other substances. Yes. Oh, see, and they don't even know, right? And they don't even know whether they've had it or not, right? Yeah. I think that's the other problem. I mean, particularly relative to other like club drugs and things. I think sometimes they're not sure. I mean, it's interesting that I think some experienced drug users will have a better sense of that and be able to start to tell the subtle differences between one drug and another. But I think for individuals that sort of in a novel way get exposed to it, I don't know how easy it would be to actually tell that apart from another stimulant drug. Yeah. So they're developing assays for different chemical compounds. But then if the chemists change them, they can change them enough that then that assay won't work again. So it's this constantly, tracking after it and usually being a few steps behind. Right. And particularly you saw it's a really high percentage of individuals in those ER admissions that reported other drug use, just like with all the other drugs that people tend to be polysubstance abusers. And so I think there's the issue of finding out what the effects of using bath salts are, but very often those bath salts might have been taken with alcohol, probably with tobacco for sure, as just baseline, and then other drugs that they might be taking. So it's going to be, I think, challenging. Oh, that's interesting. So I mean, we really don't know, and certainly I think the media hype began because of some pretty controversial and pretty dramatic behaviors, but I still go back to your point too. I think we want to be careful about that. I think we should, at minimum, treat it like we do every other, addiction. But the degree to which there will be similarities and differences, I think we just really don't know enough yet to be able to say things about that. Otherwise, let's move on to talk a little bit about prescription drug use and misuse. And I want to thank SAMHSA, the AUDIT-C, and the NIDA CTN for a few of the slides that I stole, whatever. Since I'm on tape, borrowed, and I'm acknowledging. Okay, so prescription drug use and abuse, first of all, kind of broadly. Since the year 2002, every year between 2.5 and 2.8 million Americans abuse prescription drugs for the first time. And on average, there are 7,000 new users of prescription drugs every single day. So very prevalent. This is data from SAMHSA from 2010, looking at first use age 12 and older. And you see across the bottom here, marijuana is the first column, then pain relievers and tranquilizers, and on down. The blue columns are prescription medications, And what you can see is that the prescription pain relievers attract new users. These are new users at a rate that outpaces all other drugs except marijuana. If you look at past month illicit drug use in people 12 or older in 2010, it's 22.6% for illicit drugs overall, and then again, psychotherapeutics are right after marijuana, and the numbers are in millions. And if you look at within that group, the different types of drugs, again, the pain relievers, the red bar on the top, ranks well above all the other ones. So this is looking at past month non-medical use by type from 2002 up to 2010. And the 2010 data came out more recently, so it really looks like the trends are largely continuing. So where do people get pain relievers? It looks like most individuals who use prescription drugs non-medically get their drugs from family and friends. That's the largest group. And then other categories are include getting prescriptions from more than one doctor, drug dealers, off the internet again. One of the things that I found most striking is that there has been a dramatic rise in the rate of treatment admissions for the abuse of pain relievers over the same period of time that we've been talking about, from 1999 to 2009. And it went from 10 per 100,000 for these classes of drugs to 53 per 100,000 over that period of time. So just much more likely to be coming in for treatment for prescription drugs. A picture's worth 1,000 words. These are opioid-dependent adolescents. So this is between the ages of 12 and 17. And what you can see, and this is treatment admission. So the blue circles are heroin, the black ones are prescription opioids, and in 2006, the lines crossed. So there are more adolescents coming in for treatment of prescription opioids than for heroin. In 2008, nearly 15,000 prescription painkiller overdose deaths occurred, which is more than triple those in 1999. Prescription painkillers were involved in more overdose deaths than heroin and cocaine combined. And according to the CDC, 40 Americans die every day from prescription painkiller abuse. So it's a serious problem. It has continued to be a serious problem. And this is from a really recent article in this last month in the LA Times, where they really were looking at the most recent data set available for 2010 and said, that despite law enforcement, the public health efforts to curb prescription drug abuse, the drug-related deaths in the U.S. continued to rise. The drug fatalities increased by 3% in 2010, and preliminary data suggests that the same is happening in 2011 for the time frame that was available, and that the two most responsible for that are OxyContin and Vicodin. These are causes of death during these periods, and drugs overtook traffic accidents as primary cause of death in 2009. And then the gap continued to widen in 2010. So the red line is drugs, and the blue is motor vehicles. So, yay, we're winning. Overdose deaths involving prescription painkillers rose to 16,651, and that was 43% of all fatal overdoses. So, part of the reason why this is happening is this. These are the rates at which opioids are being prescribed in this country by physicians. And what you can see is a steady increase, and that very nicely mirrors what we're seeing in terms of problems and more recently treatment admissions. The reason for that rise, though, there were a number of factors. One is that there's just been an increase in individuals with chronic pain. And because of that, there was an attention to the fact that for some chronic pain patients, they weren't being adequately treated with the system at that time. And so the prescription opiates became a way to deal with the pain and manage it better. And pain became known as the fifth vital sign in this country. And so that then sort of expanded further and further, and they started to be prescribed for relatively minor accidents or injuries. I remember it must be 10 years ago, I got a prescription for OxyContin for dental work that I'd And so they had, we had liberalized the laws some and set new medications. And there was, as always, aggressive marketing to physicians to actually be prescribing these medications. And so all of those factors have been a piece to this. And so now as people are looking at this more closely, the US FDA is considering a pretty dramatic proposal, which would be to restrict the use of these to 90 days or less if the person is not a cancer patient. Because the data supporting long-term use of opiates for pain other than cancer pain seems to be scant or non-existent, and that many of the state prescription drug monitoring programs are not being proactive in looking at the data that they have to seek out problem physicians, that they only have investigations when there's a complaint. And so they're feeling like the system is broken and that this might be a way to manage that. And so I confess personally, that feels a little bit dramatic. That feels like a big switch in the other direction, because there are some pain patients that actually seem to do well on opiates. And so I think it's going to be finding a balance, which usually happens after the pendulum swings both ways. Any questions about the epi data first that I just presented, or about prescriptions? If not, let me very briefly talk about one of the more recent studies looking at treatment of prescription opiate dependence, okay? And the slides that you'll get online are much more detailed. I just want to kind of hit the highlights of this. And so this was looking at buprenorphine, which is a partial opioid agonist. I'll talk about that in just a minute. So it has the effects of typical opioid agonists like methadone, but at lower doses. And it will produce a ceiling effect at higher doses. And again, I'll show you a picture about that in just a minute. Sublingual buprenorphine plus naloxone has been shown to be effective in the treatment of opioid dependence. There are lots and lots of studies, but most of those studies were in people dependent on heroin. And that with the growing concern about prescription opiates, as you just saw from the previous slides, we really didn't have good data on whether the same treatments would be effective. Buprenorphine is available in two forms. There's Subutex, which is just buprenorphine, and Suboxone, which is buprenorphine plus naloxone. And the reason for two things is because with Suboxone, adding the naloxone makes it less likely that people are going to abuse it and shoot it IV or divert it. So this is stolen from, I think, NIDA. In terms of like keeping all of those things straight, I just wanted to show this as, so methadone is called a full agonist, and essentially with that, as the dose of methadone you take goes up, the effect you get goes up, okay? Naloxone is an opiate antagonist, and with that, there's absolutely no effect. So it essentially blocks that. And then buprenorphine is, as I mentioned, a partial agonist, which means that there's an effect up to a certain dose, and then it flattens out. And it doesn't have that same effect going higher and higher. So again, I always have trouble keeping all that straight. So if you want to think about, in this case, a metaphor of putting a key into a door, opioid agonists, the blue line, things like methadone, would be like you're putting the right key into the door, you can open it, the lock turns, and the door can open completely, okay? Naloxone, the green line at the bottom, would be like having the wrong key for the door. So you put the key into the lock, you can't open the door, and because it's sitting in there, no other keys can be tried to open the door, okay? Until you take that out. And then buprenorphine, or the partial agonists, would be like you have the right key, you can open the door, but there's a chain on the door. And so it only opens partway, yep, and that you can't get it open after that. Okay. So the primary question that was done in this treatment study that was completed by, this was a NIDA Clinical Trials Network study with multiple sites, that I'll show you in just a minute. They decided that there was enough data that they wanted to make sure that all the patients had the opportunity to have buprenorphine plus naloxone, so Suboxone. So they didn't want to look at like with or without buprenorphine. So they decided to look at buprenorphine with or without drug counseling. And it was a really complicated two-phase study. The pictures are in the slides that I'm skipping right now, where essentially they had a phase one, really simple 1 month taper off of buprenorphine, and then anyone who was successful in being abstinent at the end of that was done with the study, but anyone who was unsuccessful with that went on to a second phase where they were randomized again and then compared to a longer period of having buprenorphine for 3 months and then tapering them off. This is here just because I thought this was such a cool slide. So these are the sites that participated. I wish I knew how to do that. These are the sites that participated in the clinical trials study that I'm about to describe. And the drug counseling that was really the independent variable here was manualized, took about 45 to 60 minutes, was based on a lot of evidence-based practices sort of combined, and did things like it provided education about addiction and recovery, recommended abstinence, had skills-based exercises, home assignments, and relapse prevention was a big piece to it. And I'll cut to the chase. These are the study findings, okay? So essentially, oh, the big button, okay. Oh, there we go. Okay, so phase 1, that first initial taper, the success at outcome, so after the taper was done, was 6 versus 7%. So no effect on drug counseling, and really, so the majority of people in this study, when they tried the short-term taper, were not successful, and they went on to phase 2. So in phase 2, at the end of 12 weeks of stable dosing on buprenorphine, you see these outcomes. So 52 and 47% were essentially successful. They were maintaining abstinence. But again, no effect for drug counseling. At the end of the taper, though, those dropped to 28 to 20 and 24%. And 8 weeks post, they're back down to 10 and 7, which was not significantly different from that. So essentially, the conclusions of that and what we learned was that tapering from buprenorphine, naloxone, whether initially or after a period of substantial improvement, led to nearly universal relapse. That the standard medical management that came with that produced outcomes equal to standard medical management and drug counseling in this design. They also looked at the chronic pain issue and whether people who were taking these medications initially for chronic pain changed the outcomes, and they found that it had no effects, that it was the same with or without. Yeah, I think there's research tends to look at things sort of more compartmentalized. So there are studies, that again, in the interest of time, I didn't present, but that are looking at, largely drugs in the class of, Adderall and Ritalin and those sort of medications. And there are clearly issues with, many of those medications. And you saw that in the first slide that I showed. It's just that the prevalence and kind of scope of the narcotics in some ways has kind of overshadowed that, but it shouldn't, because it really is, true for a number of medications. Yeah, that's a really good point. Did everybody hear that about sort of the mental health issues, that if you're working in a program where you're seeing them for mental health, and they might also be having a drug abuse comorbidity with it, that even if you can, in the case of an opiate, get them stabilized on a medication, that those other mental health issues are still really significant and often contribute potentially to why the person started using drugs and or why they might relapse. Yeah, I confess I was actually surprised a bit as I was reading just on the more recent literature again to kind of find what's really current. How, I guess I'm old enough now that I could start to see cycles, and so a lot of what I was reading in articles was about starting to look at combining mental health and addiction treatment and sort of doing more together with the two rather than sort of separated into different agencies and kind of separate doors. And we were talking about that back in the 80s, and it became very popular, and there were lots of dual diagnosis programs that were sort of opened, and then it sort of fades and kind of goes back, and now people are starting to sort of rediscover how important that is. And, for a long time we were just having the discussion of which one to treat first, and kept it sort of as the norm that it has to be one door or another, when in fact really it's about potentially how to treat them together. So why don't we move on to the case study? So everyone had a chance to read the case study. We sort of had an intro to that. What are the general thoughts about this patient and in the realm of drug use? And we can talk about mental health too, but particularly substance use. So we heard about the first visit to, so she, in addition, it turned out that she had a history of tuberculosis. So as you read the case, can anyone tell me what they found in terms of her substance use? She didn't have any, so there was a statement that said she didn't have any substance use disorders? Or she wasn't using drugs? Or she wasn't drinking? I'll help folks a little bit so we can talk about it. Unless I missed it, I didn't see it mentioned. So what do you think about that? Yes. It's the same case. We're all going to be talking about the same case. So the one that we just discussed.
Referring to the same case, we kind of want to look at it, okay, well, how about the same person, but in a mental health or addiction facility? How do we deal with this client in that setting? And that's how we're going to refer to it in each lecture. Okay?
And actually, I would just add a little bit to that I want to talk about addictions, but actually across all the settings that you hear about in the case. So there's no mention in there about substance use dependence. So okay, so there was no screening. It doesn't sound like at any of those points in time. And screening in what way? What do you think? So what do you think should have happened? So a tox screen is one option. Right, SBIRT. I thought that this case is a great illustration of where SBIRT comes in, and that that in a number of those sites that the CDC recommendation is that that screening is universal. So it really should be that that you're thinking about that with every patient that you see, because remember, it's just a couple of questions. Screening is meant to be brief, but that it's really important to ask those questions, because otherwise that could be playing a large role and you're not going to necessarily be aware of it. Absolutely. I have a colleague, Steve Andersma, who really, that's some of what we've been looking at, is how to make some of this computer directed, where you could actually, Steve has developed a program where you wear headphones, it's a tablet computer, and the screening questions actually get asked by this fat green parrot named Petey, who will actually direct them through the questions and can actually then do pieces of motivational interviewing with them. But yeah, that's not going to happen anytime soon. But we started to go off in that direction because there is this huge disconnect. There's a huge disconnect between what the research has shown consistently. The research shows that if you do SBIRT, you're going to be able to, with a percentage of the people that you do it with, they're going to change their behavior. It will actually by itself be sufficient to be an intervention. And for other cases, it can be prevention to stop it from escalating. And for others, it can be the bridge to get into treatment. Now, not 80% of them, but but in many studies, it can be 20% of them. Okay, so if you can do that with 1 in 5 people, that's really important and valuable. But the problem is figuring out how to make that routine in the settings where everyone's busy. And there was a study once that showed that if a physician actually did all the things he or she is supposed to do at screening, it would be 4 hours per patient. Because everyone's coming with sort of like, this has to happen. But I think because addiction really can impact so many of the other things that we're talking about, I think particularly in these settings, you should be able to do the screening, and it's called brief intervention, in 15 minutes, 20 minutes. And just that, I can't emphasize enough, the Clinical Trials Network did a study where they looked at motivational interviewing, which is largely has those same principles of trying to really look at pros and cons, and in a very non-judgmental way let the person decide whether and how they want to make a change. They found that if you took a counselor at intake and treatment, and in the experimental group they did 20 minutes, and this is going into addiction treatment, so not a regular, but coming into addiction treatment, they did 20 minutes of just that non-confrontational motivational interviewing. And then they essentially stopped and they did all the paperwork and the usual stuff you have to do for intake. And then they did about 10 minutes more of motivational interviewing at the end. So that became the intake assessment. And they compared that to a group where the counselor just did the usual intake. Just that, with no other motivational interviewing, with no change in the rest of treatment, with everything else being business as usual, they had a difference in rates of engagement, in rates of drinking, even like 30 days later. I mean, it amazingly dramatic effects. And so I think that reaffirmed to me that those same things can be happening in a variety of settings. And so I think it is trying to find the way to do that. That's what I was showing you in terms of kind of new things. I think the briefer you can make the screening piece, the better, so that you really can spend your time on actually being able to start to think about brief interventions with them, you know. And that I think part of why it's been a struggle in the field too is that the brief intervention piece takes some training. You know, it doesn't necessarily sort of happen automatically, sort of, and so it's difficult to sort of get people together to do that. Yes. All right. So I'm at risk of not being able to repeat all that because it's longer than my brain's able to process. But so essentially, let's start with the first part. So the first part is can you do a brief intervention kind of amidst other things that the person that you're seeing might be having done at whatever your site might be? And that's a great question, and the answer is absolutely. So you know, one of the sites that has found the whole SBIRT thing to be most effective are hospital ERs. Okay, and at first when I read that, I didn't believe it because of talk about chaotic environment, etc. But it really does seem to have an effect, and in some of the studies, they actually were able to train the physicians to do this. But in other cases, it was nurses or you know, essentially, you know, counselors that came to work in that setting. But when you watch the videotapes for training in that online, almost all of them are like while they're stitching up the person's leg, they're doing the brief intervention, you know, or while they're setting so it really, because of the style, because it's not about confronting them, it's not about saying you've got a problem and you need to go to treatment. It's really about talking to them about their substance use. And, you know, and recognizing that there are good things related to drug use, or else they wouldn't be doing it, but also not so good things, and getting them to start to sort of weigh what the pluses and the minuses are and think about moving in the direction of change. So the short answer is yes. In terms of the referral to treatment, there are probably differences in different settings, but in general, I think having a list of possible referral sites made up to be able to give to the person that would include places that they might be able to get into treatment is wonderful. I think, you know, meetings like this and actually being able to meet people that work in the different sites and establishing connections is wonderful. And I don't believe in most cases you would be liable if you didn't follow up with the person to actually make sure that they did do that. But there might be some settings in which that could be an issue. But in general, no, it's really about, you know, providing them with those resources. And again, if there are sites where that's prevalent enough, actually having those connections is wonderful. If you can actually, you know the name of the person they might be talking to. In some cases, people actually pick up the phone and help them call to make an appointment. It depends upon the setting and how in part the first session went. But yeah, this isn't meant to be sort of just a one-shot deal. You know, if you have the luxury of seeing the person repeatedly, then looking at ways to not necessarily do the whole thing all over again, because but you're sort of affirming what their current status is relative to before, and then often you can look at, you know, the brief intervention could move toward more of the kind of brief treatment. If you get to see them repeatedly, you can keep having that conversation with them. You know, change doesn't happen for most people, you know, immediately. Think about the things that you want to change for yourselves. If you're trying to quit smoking, if you're trying to exercise, if you're trying to lose weight, we all need to, you know, and that's what we do. We weigh the pros and the cons. We think about, you know, so, and it's offering encouragement if they are making a change and if they've been successful, even if it's cutting down, you know, and then trying to look at sort of what the next steps are. This really can be used very effectively on an ongoing basis. Great question. Okay, thank you very much.